Hello.
Yes, we can start. Yes, please. All right. So we'll continue with our topic for today is on management of PPH, which we already know. We have all come across one way or the other with somebody who has given birth and she's bleeding. So I believe that we have all handled it once or many times. And so we want to find out what are some of the causes of PPH, postpartum hemorrhage. Causes of postpartum hemorrhage. So I think that we all are familiar with the causes of PPH, which has to do with the 4 T's, which all of us have idea about the 4 T's. When we mention the 4 T's, we are talking about trauma, atony uterus or boggy uterus or tone. Then we talk about tissue, where maybe the placenta and its membranes are retained. And then also we talk about the thrombin, which has to do with the bleeding disorders which the woman may have. And so management of this postpartum hemorrhage depends basically on the cause. So if it has to do with the tone, then you know what we have to do. Tissue, trauma, and then thrombin. You know how to do or deal with all these things. So basically, the general management for PPH has to do with the immediate first thing after delivery of the baby and the placenta has come out. What do? We all know. We massage the uterus into contraction. And then we make sure that we give our uterotonics, the oxytocin, and the uterus is held in very firm contractions, making sure that the bladder is empty. Yes, the bladder is empty. Of course, the woman will be free from, sometimes when the bladder is full, it actually competes space with the uterus. And so it prevents the uterus from actually having its own time to contract. Okay, so you release urine from the bladder so that the uterus will have the space and then the strength to also contract very well. If after giving all these things, the uterus is contracted, this woman is still bleeding, then we find out that maybe there is a problem, a trauma around tear at the perineal area. Maybe she was given an episiotomy, and so we try to take care of the bleeding areas. If it has to do with episiotomy, tears, make sure that they are sutured to reduce the bleeding or stop the bleeding altogether. If it has to do with tone, then massaging the uterus very well, as I have already said. And then you set up an IV, having given your uterotonics after delivery of the baby, placenta comes out and there's still, sometimes the placenta may be partially expelled. That means that some of the tissues may be in position and they may be causing because it serves as a foreign body to the uterus. And so the uterus will be bleeding, will refuse to contract, and the bleeding will be coming out so much. Okay. And then sometimes it has to do with thrombin, bleeding disorders. And so with all these things in view, that means that we have to equip ourselves to help the woman. That is why every pregnant woman who comes in labor would be given an IV, or you set up a cannula in position. Blood for grouping and cross-matching would also be taken, so that in case of any emergency. And so if the woman, after all these things, she's still bleeding, that tells you maybe there is a problem with the clotting factors. And so you also will test it by picking some of the blood in the bottle to also check the clotting time, and that all that is needed to be done. And so these are the general managements which will be given or done for a woman who has delivered and then she is bleeding. Then we have to also make sure we assess the blood loss, and then appropriately document how much the blood loss has been, especially when we have the measuring jugs or calibrated receivers, which we can use to identify the amount of blood that the woman has poured. Okay, and running infusions, giving her something to eat, they are all of proud importance. And then putting baby to breast if baby's condition is also good with the mother's own. If she will not go to the theater, she's on the ward, she's being monitored, then the baby can also be put to breast to stimulate the outflow of the oxytocin through the system, which will also help to contract the uterus very, very well. So all these things come into play to reduce the postpartum bleeding or postpartum hemorrhage. And then some of the things that we can do, apart from all the things that has been done, we can also use the condom or balloon tamponade. We can also use the bimanual compression, and then compression on the aorta, abdominal compression of the aorta, to also prevent the bleeding. All of you. Oh. Okay, we are checking. Ben, some are saying that the open is still connecting, they are not connected. And so please, can you check for us? It means that I have to go over again because most of them are complaining from the class.
I've paused the recording soon. Or should I continue?
You pause the recording?
Just now.
Just now.
When you go to the phone call, that's when I call.
Oh.
So I'm going to check. But I'm Mr. AC.
Okay.
Didn't anything about that.
Okay.
When you try to connect,
it's still rolling, it's still connected. They cannot be connected to the Zoom.
So should you want to go there or so the issue has been resolved?
No, you check if there is something wrong over there so that we can.
Okay. Yes, madam.
Can you mute yourself?
Okay. All right, so we continue from wherever we left. So I was with the general management of PPH. And then apart from that, I added that we can do the condom tamponade or balloon tamponade, and then abdominal aorta compression, as well as compression of the uterus, bimanual compression of the uterus, while we put our hands into the mother, the vagina, into the uterus, the anterior funnels of the uterus, and then the left hand or one hand will be on the abdomen, trying also to hold on to the posterior funnels of the uterus and then pushing together to cause pressure being applied to the uterine walls. And this one will also prevent bleeding. So these are some of the things that we do. If maybe after doing that, there is no proper solution, then the action of the specialist may come in to help solve the issue. In the peripheries, we'll refer with a note, whatever has been done, to the tertiary institution for management. So this is what we want to do this afternoon. Please, does anybody have any question to ask or before we continue? Any question? If we don't have any question, then we'll proceed on to do what we want to do just this afternoon. Okay. So, Auntie Mary, after delivering, you see that you are still bleeding. So I want to take care of the bleeding for you, okay? So that she said,
with the management, can you start from anywhere or is there an order to follow?
okay, I mentioned that with the management, the general management can be given to anybody who has started bleeding after delivery. And once you started bleeding, the general management is that you set up an IV infusion, you take blood for grouping and cross-matching, you carry out your vital signs recordings, and then the basic thing that we normally would do is so that once the placenta has come out, you will massage the uterus, expel clots, and then pass a catheter to drain the bladder. Let's see if the bleeding will minimize. If then from that step, we go on to examine the vaginal area to rule out any tears. And so we come to trauma. So you see that massaging the uterus has to do with tone of the uterus. Is the uterus contracted or not contracted? If it's not contracted, you massage well, expel clots, and then you drain the bladder to make sure that the bladder is contracted. If the bladder is contracted, she's still bleeding, go down the perineal area to check out for any tests. If she is bleeding, if she has an episiotomy, if she has a tear, vaginal walls inspection, and all those things, as we normally would do. After that, she's still bleeding. What is the cause? The cause may be due to thrombin. That has to do with maybe clotting factors. And so if that one comes in and she's still bleeding, we collect all the blood, we measure, and the blood loss, we all know, if somebody bleeds about 500 mils of blood, it means that she has PPH. And so the action is that we set up an IV infusion run, and then we make sure that she's stable. And then if she's still bleeding, there may be the need to transfuse her with plasma if it has to do with the clotting factors so much. And so when all these things are done and then she's still bleeding, that's what we will add the other things as I've mentioned that we want to try and do. Compressing the abdominal aorta, which is from the umbilicus area slightly to the left side. So you make a fist and then press your hand over there. For example, it goes this way. So with this, I'll just wear a disposable glove and then do that. Having informed the woman that this is what is happening, we have done all, but we are still trying to control bleeding. And so from the umbilical area to the left, where we have the large aortic vessel over here. So you make a fist like this,
your screen
and
is
then
not sharing.
you press, and the pressure that is being applied, then it means that you need somebody, or if there is nobody around, the left hand will come to the femoral area to palpate the artery over there, whether it is pulsating or not. And so you can use the left to apply it over here, press it downwards, and then the other hand will use to palpate or feel for the femoral artery there. If the pressure that is exerted on the aorta is very strong, it will seize the arterial vessel from supplying more blood to the uterus. And so it means that we are gaining a control over the bleeding. If the pressure that is applied here is not too strong, when you feel the femoral artery over here, you still feel that it is pulsating. Once it is pulsating, it means that the pressure applied here is not strong. And so it means that you have to increase the pressure down so that it will cease the blood from flowing downwards. So that is the application of the aortic compression, abdominal aortic compression. So you go down, it's the aorta is between, it's from the umbilicus down to the left side. So it goes like this. And so you make a fist, and then the knuckles and the upper part of your palms will go on, and then you exert the pressure, while the other hand will come and then feel for the vessel here, the femoral artery, which is supplying blood. So like I said, if the pressure applied here is very strong, it means that we are gaining control over the bleeding, meaning that the blood supply that is coming is ceased.
Did someone ask, what's a topic are you choosing?
PPH, management and PPH. Management and its PPH. So, okay. PPH is management, general management, and then other management that can be also used to curtail bleeding this thing. And so that is the femoral tap, or the aortic compression. Aortic compression. Apart from that, you can also go in through the vagina into the uterus, the anterior funnels of the uterus, and then apply pressure, while the other hand is on the abdomen, on top of the abdomen, also holding onto the posterior funnels of the uterus to also exert pressure, so that the two will eventually come to meet. So you are bringing the anterior and posterior together so that the uterine walls will meet together, and that can also exert pressure on the bleeding vessels. The idea is that you want to reduce bleeding from coming. And so what we do is that we wear gynae gloves or surgical gloves. And with surgical gloves, because we don't have gynae gloves, we wear surgical gloves, and then we remove the pad. Auntie, I'm removing the pad for you so that I can do the cleaning, okay? Sorry. So I'll go in. Auntie Mira was I'm entering into. And so my right hand has gone inside. And then I'll go as far as pressing the anterior funnels of the uterus, whilst the left hand will also hold very deep, and then the two will come and meet. So this one, the right hand is meeting the left hand. The left palm is meeting the right fist inside the uterus. And so with this, we are bringing the anterior and the posterior uterine walls together. The idea is that we want to prevent or help the vessels there to be pressed so that the bleeding will reduce or even cease. So it will be there for about 15 minutes. So you see that it's not a small joke, it's not a joke at all, because It has to be there for at least 10 to 15 minutes before you remove your hand slowly, and then you check again whether the woman is still bleeding or not bleeding. So that is the idea that we do. So with these two, the bimanual compression and then the aortic compression on the abdomen, if it is applied very well, it may reduce the bleeding that is coming. Now, if all these things that has been done is not effective so much, the next thing we will do is that we'll go in with a condom tamponade and then help reduce the bleeding. So at this stage, I will remove my glove and then place the infusion on the I want to hang it here. Let's see if you can hang it for me. Good. So, yes, thank you. Auntie, please raise your leg a little for me, okay? And so, once we are there, now, okay. So it's connected to, so Auntie, sorry, I'm placing this inside your womb for you, okay? And then once it enters, I will. So you see that it is draining. So you can fill it up to about 300 to 500 mils of normal saline. And this one, as it's being filled up, is going to increase the size. And then with the size, you see that it will also cause pressure in the uterus. And so it will also reduce the bleeding that is coming. And so the condom tamponade or balloon tamponade. Okay. So once it is running, it can run and then bloat up and then causes pressure to the bleeding points within the uterus. And so once it is running like that, all that we'll do is that we observe the woman, check her vital signs, make sure that she is not in shock. And once it's inside, this can be in situ for 6 hours to 24 hours. And then when the bleeding reduces or when the bleeding ceases and you want to remove, you don't remove it at once or suddenly. What we'll do is that we'll use syringe and then draw the water gradually, about 50 mils, 50 to 100 mils per hour. Gradually, then we'll be draining, reducing until the whole lot, the 500 or the 300 mils that was set up, is drained out before the whole condom or the balloon tamponade is removed. So this is also another procedure that can be used to reduce or prevent or to manage PPH. If the bleeding is, you still put a pad over there to check out whether she is still bleeding. Having gone in to bring out all the clots that are inside, then you put another pad there. And so you'll be monitoring the woman from time to time. Now, if all this drain and then you give the woman something to eat, you check her vital signs and everything, she's actually improving. Now you remove the pad, there is no bleeding. All right, if there is no bleeding, then what we are going to do is that you take a syringe, 50 cc, and then you drain 50 to 100 mils, 50 to 100 mils, so that gradually, within 6 hours to 24 hours, everything might have come out. And then Auntie, who has delivered, is now feeling comfortable. Uterus is well contracted, and then bleeding has minimized. She's feeling fine. And so she will not be discharged immediately. She has to be put on antibiotics because our hand has entered so much into the uterus. And so these are some of the ways that we can use to also help the woman or deal with PPH. So I think that our management of PPH starts from the initial one that we do, every midwife will do after delivery of the woman. And so if bleeding continues, then we find the source of the bleeding and then we correct it. But the most important thing is that we should make sure the woman is in good health. And then whilst this one is on, sometimes you can also set an IV with oxytocin on.
Is someone doing this procedure, will you still massage the uterus?
With this procedure? No. You don't massage. The massage is the initial one. Once you put this one inside, the condom inside, you don't massage the uterus. We are waiting, we are expecting that the condom, which has had a full of 500 mils of normal saline, will expand the condom or the balloon, and then it's going to exert pressure on all the bleeding vessels within the endometrial lining. So definitely, we don't need to massage. That is why when if bleeding has ceased and then we are removing, we don't drain the water all the water immediately. No, we do it gradually, and then we observe if the uterus will come back to relax, and then the bleeding will come again. And so if that thing happens, it's telling us that maybe she's having this thrombotic problems, which has to be taken care of. And so that is how it goes. Management of PPH, and this has to do with our taking care, proper care of the woman, and then also observing all the blood that is coming out.
Another person asks, how did you connect the catheter to the gloves?
The catheter, okay, I inserted it to the gloves and then I tied it. It goes this way. There is a tie around. Please, can you see it? The catheter is inside the condom or the glove. And then I gave a ring around here too, so that even if you pull it, it will not come out. Please, have you seen it? Can you see?
Yes.
Please, can you see?
Yes, sister.
Yes.
All right. So even if you pull it, it will not pull it out. It will not come out. And even if you turn it, the water will also not drain. Can you see it? Even if I turn it, the water is still intact. It's not draining outside. So that is how it is done.
Oh, smart.
Do we have any question to ask?
Sister, please, how
So
many
when we are done,
minutes of this
remove all your things there, and then
Okay,
you make
60.
sure that you discard all the items used, and then you make sure the woman is comfortable. But then all the blood that came out, please, we must measure and then notify or record the amount of blood. Even if you are not able to you couldn't measure the pad, the number of pad that has been used should not be discarded unrecorded. Please, the number of the pads that we use, so that if each pad is well soaked with blood, or let's say you put water on, put about 500 ml of water on this, or 300 ml of water on this, you see that when you raise it, it will be dripping. And once it is dripping, means that full soaked pad, the amount of blood loss is about 300 ml. So we shouldn't easily discard pad that has been used. Even when you are doing deliveries and then, for example, you give episiotomy or the woman has a tear, before the baby comes out, you see that the woman will be bleeding, pouring. Sometimes you put some pad at the perineal area while the baby's head has not yet come. It gets soaked, we pick it and then we put it aside. But we don't take it into account that all the blood that has been soaked on the pad, they are from the woman. So it should be added to the blood loss. Should be added to the blood loss. So please, this is somebody is asking a question. She said what?
No, the person has the answer, but I'm not going to translate the question.
Okay, then give me that so that, or you want to increase them? Okay. Hello, who is the one who has a question, please? Somebody raise her hands up. He's gone.
No, gone.
Hello, your hands is up.
Hello, sister.
Hello.
Yes, please. My question. Hello, sister. My question is the question of the abdominal aorta. How long should that be for, since we are impending venous return from the femoral artery? How long should we hold on to or compress the abdominal aorta to prevent ischemia to the femoral artery?
I mentioned that 10 to 15 minutes. At least by 10 minutes, you would.
10 to 15. Yes, I thought that one was for the that compression. I thought that one is not for the abdominal aorta. That one is for
the compressions are the compression of the aorta, abdominal aortic compression. Please listen. Abdominal aortic compression. That is where when you apply the pressure, then you feel for the femoral artery. And then we have the bimanual compression. So the compressions are two, please. Have you gotten it?
Yes,
compression
please. So the 10 to 15 minutes,
will go for
the 10 to 15 minutes was for the
aorta.
bimanual compression. Aorta.
The aortic compression. And then the bimanual one. The bimanual one is from 10 to about 20 minutes.
Okay.
That's where sometimes about 30 minutes. That was why I was saying that it's not a joke. You see?
Yes.
Yes, it's not,
Shut up.
because standing for about 10
Human.
to 15 minutes, you may easily get tired. But then because of the woman, so that if you are able to assess that and there is a chair, you can even sit down. Somebody should give you a chair, raise up a little so that your waist will not pain you. Like you are.
Okay, sister. Thank you.
Okay. It's like you are doing a suturing. You can't stand and do suturing. And by the time you finish, your waist is twisted. So you always have to sit down. But sometimes you want things to be quick for us. But when you sit, you are relaxed, you'll be able to do it nicely, especially with the spotlight and everything over there for you. And so these are some of the management we can also use in addition to having palpated the uterus, passed the catheter, checked out there is no trauma at the perineal areas. But still this woman is bleeding. What should we do? Let's try this once. At least 3 of these, one of them will work. Apart from that, if she's still bleeding, then you think of the thrombic problem, that is clotting factor dissemination. And so you look out for a solution to that one. Can we mention some complications? Some complications of postpartum hemorrhage. Hello. Hello.
Please, with the condom, please, with the condom tamponade, when would you, after filling it, when would you start draining? Please, with the condom tamponade, after filling it with water, when would you start draining some from it?
When will you start draining some from it? Come again with your question, please.
Yes, please.
Okay. I mentioned that when you place it there, you'll be observed because her pad, before you do that, you bring all the clots from the uterus. You know, when there is clots, when there are clots there, she may be bleeding. But when you remove the clots, clean the area, and then you apply a new pad, you clean and then you do the condom tamponade. Then you put a pad over there. You'll be observing this woman for, in fact, it should be in for 6 to 24 hours. Now, after 6 hours, you realize that the bleeding is reducing. Don't take it away. And so the woman will still be on it after 6 hours, 10 hours onwards. If all the bleeding ceases, or if the bleeding has really reduced to the minimal, as you as a midwife will stem that the bleeding is from 6 hours onwards, then you begin to reduce the amount. I mentioned that you can use 50 cc syringe to drain. So you take about 50 mils gradually. Then the next 1 hour, every hour you do the removal, every 1 hour. So 1 hour you take 50. The second hour you take 50. You've taken how many? 100 mils. So the second hour, then you can take about 100 mils, 50-50. And so you still be observing within that 1 hour, how is the pad? Is it still soaked or it has reduced? Okay, and so gradually, you will remove all the infusion from there, and then you place your pad. Don't pack the uterus. Just put the pad there, still to observe if the uterus will relax. Your network is not good, though. Okay, and so to end it, when all the infusion has been removed and then the pad there, now this woman is fine. All the vital signs, check the BP, the pulse, the respiration, her attitude, and then she has been able to take in something. She can even sit in bed and then urinate herself and the rest. So we realize that at this juncture, she's doing very well. And so she has to be monitored. That's why I said she has to be monitored and then put on antibiotics, because our hands has entered the uterus after delivery and all the manipulations that has been done. She needs antibiotics and then analgesics to prevent infection. And so she'll be observed for at least 24 to 48 hours. When the antibiotics she has covered the antibiotics, then if she's very active, mobile, then you assess the situation before you discharge her. However, if all these things fails, then that one from your center, you refer. If you are in a tertiary institution, the OBGYN specialist will come in and then they will know the actions they have to take the next time. I asked a question, what are some of the complications of PPH?
Anemia.
Anemia.
Sheehan syndrome.
DIC.
Sheehan syndrome.
Shock. DIC.
DIC.
Yes.
Yeah. Infection. But another point, come up. I didn't get. You said what? Death. That may be the last resort.
Sheehan syndrome.
Sheehan syndrome. Somebody has mentioned, but you are topping it up. It's good that we know all these complications that may come. And so as a midwife, we always
Kidney failure.
Kidney failure,
Heart
sure.
failure.
Heart failure.
Then
Recurrence of the PPH during subsequent deliveries.
Recurring of PPH during subsequent deliveries. And so you write it boldly in her antenatal book with red pen, double red pen, severe PPH in maybe her second delivery, so that the moment she comes to you, you know the care that you are going to give, that she is at risk. She is at risk. However, please don't forget, I think I omitted that one. Before you even set up, do the condom tamponade, there should be a catheter in utero connected to a urine bag to monitor, so that if the kidney is failing, we will know. And then some complications like dehydration. You know, shock and dehydration actually moves together. Once she's bleeding, she's losing a lot of fluid, electrolytes, imbalance, and all that comes in. And so we must be on the alert to prevent PPH. Some of them can be prevented. Some of them can be prevented. And in fact, how do we prevent PPH? How do we prevent PPH?
Proper history taking.
Proper history taking, sure.
Active management of first stage of labor.
Please, when we ask such a question, start from the ANC, including all the education that you give over there. Somebody mentioned history taking. I was expecting that somebody will add up the educations and then treating of infections from the ANC before she even gets into labor. So that if we ask, treat anemia, so that if we ask such a question in an examination, you can get more answers when you divide them into ANC, labor, and the rest. So with the ANC, the history taking, and
Physical
then
examination.
critical examination, and then dedication on what? Prevention of malaria, nutrition, they all come in. And then exercises to strengthen, especially with the CODeL exercise, to strengthen the pelvic floor muscles, sure, to prevent future tests. Are we getting it? And so we have a lot to learn. So you can prevent it from the ANC. When she comes into second stage, what happens over there? When she comes into labor, what happens there? From the first stage, of labor.
Okay. The use of photograph to prevent prolonged labor.
To prevent prolonged labor, we have to use a photograph. Very good. What again?
We should avoid interfering with the uterus.
Oh, double answer. I didn't get anything.
We should avoid interrupting the contractions of the uterus by using uterotonics.
By using uterotonics. But then if there is a problem, if the contractions are weak, what do? You will give it. But then when we give it, we have to do the titration very well. You set 5 units in 500 mils of normal saline. You write your time, the date, the drops per minute. The increasing is where the problem lies. That is known as titration. So if you start with 15 drops, every 30 minutes, you have to increase it by how many drops? 5. So 15, you go to 20, you go to 25, you go to 30 drops. Now, if you reach the 30 drops and the contractions has increased for, let's say 2, it means that she is improving. If she was having 2 contractions, now she has about 3 or 4 contractions lasting 40 seconds. Don't increase again. Maintain the 30 drops and watch this woman. Observe her closely. But if you don't increase, you see that the infusion will run and then it will get finished. Then the labor will not be able to progress. The contractions will cease. And then the next moment, this woman is sleeping. Have you observed some before? Yes. She's on oxytocin infusion. The next time she is sleeping because we have not been doing what we are expected to do. So please, let's take note of that. Yes, I'm telling you the real story. And so let's continue. We haven't finished with the prevention. We are still in the first stage. So breathing exercises. The woman should be reminded of the breathing exercises in the first stage of labor. And then passing urine as and when she feels it. And she must take in food as well. So in the first stage, you realize that we have a lot to do over there before she even gets into the second stage of labor. So second stage, what happens over there? When she's fully dilated, she's placed on the delivery bed.
Yes, sister, please, with the second stage, you have to educate her well on how the second stage of labor is going to go, the procedure. So you tell her to bear down when the contraction sets in. So she won't bear down abnormally to end up having tests. And also you also educate her on educate her and make her know that she has to put her buttocks down, not raise, because some people do that and then they'll end up having very bad tests. And also in the second stage, guarding the perineum also very well to prevent by the midwife to also prevent the test.
Okay.
That's the lesson I can say.
What again?
Sister, please giving timely episiotomy in order to prevent a tear, severe
extensive test. Okay, so you as a midwife, you use your judgment correctly. This time, this perineum is tight, so I have to give episiotomy. So you time it and give it at the right time. You don't give it too early or too late. That is the meaning of timely episiotomy. If you give it too early, this woman will be bleeding small. And then the head will be receding in and out. By the time you realize the cut has extended, by the time you finish, the apex is almost reaching where? Above so much. And so you don't have to give it so early. And then you don't also have to wait until the head is almost crowning. And then you see that the perineum is tearing. Then you cut through. By the time you finish, the tear would also might have extended so far. And so judgment, use your judgment correctly, give it at the right time. And then you see that you prevent the woman from hurting herself. You, the midwife, also prevent yourself from being so tired. Oh, this labor, this labor has been difficult. And so we have to use our judgment correctly and then rightly, giving it at the right time to help her, help yourself also to make the delivery so pleasant. All right. What about the third stage? So you see that prevention has so much from ANC, first stage, second stage, and then the third stage. What happens over there? Prevention of PPH in the second stage, third stage, sorry.
Hello.
Hello. Hello. Hello.
Empty the blood. You empty the bladder.
Empty the bladder.
Yeah. After you empty the bladder, you make sure that the uterus is empty. You palpate the uterus, so to expel the clots.
At third stage, you haven't delivered the placenta. You give your oxytocin after the baby has come out. And so that is where third stage starts. After palpating that there is no second baby in utero. Then you give the oxytocin. And then you do active management of third stage of labor. So you deliver placenta by CCT. Now, after the placenta has come out, immediately massage the uterus into contraction. Once you have controlled bleeding, then you examine your placenta thoroughly. From the fetal surface, from the cord to the fetal surface to the maternal surface, to make sure that none of the lobes have retained. And so you realize that you can prevent PPH from all these areas, and then the woman will have no problem as such. Anything to add up with the prevention? Anything? Any other points? Any other points?
No,
Yes,
sister.
Yeah,
yes,
sister.
sister. Yeah, come on.
This is at the fourth stage, you monitor and palpate the uterus every 15 minutes.
and ensure the bladder is always empty.
Okay. And on the 4th stage, you haven't finished. There is more.
Sister, please, you have to check the look here, the color, the amount, and the consistency.
Sure. So over there too. And then the next point over there in the 4th stage is what?
Please, checking of vital signs.
What?
Checking of vital signs of the client, especially the BP, also tells you if something is going wrong.
Okay. Another point.
Please, after delivery of the placenta, you have to also check to make sure the lobes are all there, so that there wouldn't be any lobes retained in the uterus.
Okay.
After that, you also examine the woman for any trauma.
After delivery. Yes,
please.
Okay. You examine the perineum for any. Okay.
So in the baby will be put to breast within 30 minutes.
That is my point. Very, very important. Why do we have to put this baby to breast after 30 minutes?
Please, within 30 minutes, the baby can help induce oxytocin, which will help in the contraction of the uterus.
Of the uterus, good. And so we have to qualify that if baby is healthy, sometimes a baby will be delivered and she's asphyxiated, and the baby will be moved to MBU. This woman too, we are now checking her. How would she receive the breastfeeding after 30 minutes? What happens that time, the time that the baby has been separated from the mother to the time that the woman is cared for and then she's fine? What happens? What do? We have come across severally with babies in that situation with their mothers. What happens to them? What do we do to the mothers and then to the baby as well?
Please, sister, you can stimulate the breast yourself.
You can do what?
You can stimulate the breast.
The mother can stimulate the breast or the midwife? The
mother.
She can stimulate. She can stimulate the breast.
The breast.
How does she? How would she do it?
She stimulates the nipple with the hands.
And then the breast milk will be flowing, or what?
No.
Or that one.
Immediately after the delivery, there will be no breast milk. But if she puts
there's breast milk. Some of them. Majority,
yes.
At the ANC, you see that
the colostrum will be covering the colostrum will be covering the breast unless the baby sucks it, that the breast will start flowing out.
But colostrum is also part of the breast milk.
Yes, sister.
This topic is very interesting. So we are all coming up with what we have experienced in our various centers, our various facilities. It's good that we come up with whatever. Yes, somebody was trying to come up with a point.
You can express the breast milk for feeding. Such a case.
Feeding.
You express it, give it to them for feeding.
Now, if the woman is healthy, bleeding has reduced, and then she's able to take in something, can she be helped to the MBU to also go and see the baby? And sometimes even over there, the baby can be put to breast. Or
that is what we do.
Sometimes even when the baby is resuscitated and the condition is fine, some of them even are brought to their mothers for them to start the breastfeeding. And you know, breastfeeding naturally brings in a lot of bonding and then satisfaction from both the mother and then to the mother and then the baby as well. And so we look, like I'm saying, midwifery nursing, it's dynamic, it changes. And so we are not using a fast rule like this is the way it should go. No. If there are changes, the alternative should be applied so that both will be satisfied. And so I think it's good we all go this way so that baby and mother will be happy. Okay. Any other question? Any other question?
Hello, sister. Please, at the ANC, when you want to check the estimated fetal weight, I'm thinking about I don't know why I will classify under it, how it will help. Whether it can also help to prevent PPH. Like if you check and know that the fetal weight is more than the normal one, and you instead of you to let the woman deliver by herself through the difficult labors, you can get her all those things at ANC. So such a woman can book for a CS to prevent all those things. So I don't know whether it's also correct point.
Okay. You know, big baby can also be a cause of PPH and then multiparity and then multiple twins.
Yes.
Yeah. Now, if a baby weighs, let's say, 4.2 by the scan, maybe at 36 weeks, the woman will be monitored. You know, sometimes it is the doctors who actually take the final decision on the weight of the babies. But the midwives actually who do the focus antenatal in your areas, you also have a point over there. Because if the woman goes for the scan and then she comes with this heavy weight, you can as well refer to maybe the rightful place she has to go based upon the weight of the, and I think you do it a lot, referring from maybe a periphery point to maybe a tertiary institution, which is a good point to that effect. And so you are not far from wrong. It's also part of managing and then thinking of safe motherhood. How many, Ben? Hey, Wanda. So do we have any more questions to ask? Otherwise, we would. Please, I mentioned management of PPH is very, very crucial to the midwife. So please, all of us should make a point to prevent the woman from having PPH, which is also a killer disease, as I will put it, so that we will prevent maternal mortality as well. Prevention of maternal mortality. Yeah. So please, we should help ourselves, help one another, so that all of us will enjoy our delivery. Stop the recordings. That's okay. I just want to repeat a few points.
Hello, ma'am.
Hello.
Yeah. Please, when you were teaching the condom tamponade, I heard you mention that we have to also insert a catheter in the uterus and connect it to a urine bag.
I
Please,
didn't
can you
say.
show?
Did I mention uterus? I said we can insert urethral catheter.
Okay.
To monitor the urine.
Oh, okay.
You know, the complications that we mentioned, that the woman can also have kidney failure. Now, if you don't know the urine output, how can you say that somebody is having a kidney failure? Are you getting the point? At least with a normal flow of urine, at least every 1 hour, 30 mils of urine should be passed. Now, if you place a catheter there and then within 2-3 hours, just about 60 mils of urine has come out, it's not a good sign. It's a sign of either dehydration or something is really happening. So you set an IV, increase the rate of the infusion that is flowing, and then you observe whether the urine output will increase or not. That's what I meant. Okay.
Okay, ma. Thank you.
You are welcome.